uh, class on clinical examination of the neurological system. So, without much delay, we will start with the today's topic on clinical approach to epilepsy. I hope all the attendees have read something about the basics of epilepsy. And now over to Dr. Joshi, sir. Sir, you can start, sir.
Yeah,
The
yeah.
first slide.
1 minute.
Yeah, no problem, sir. Take your time.
Okay. Can you see the slides now?
Yes, sir. Yes, yes.
Yeah. The top, this one, how do I minimize?
No, it's okay, sir. You can present, sir. No issues.
Yeah, because I can't read the slide. Because of this.
No, sir, you enlarge your PPT as usually you enlarge it.
Yeah. So
Go to the slideshow, sir. Yeah, fine, sir.
yeah, these information, no, from this thing, I am trying to minimize it so I can see my slides fully.
Uh,
Hide
Sir,
the names
go
of.
to the view and just put full screen. Go to the view,
Uh,
just give full screen.
it's full screen only now.
Yes, sir. This is how the zoom comes. The other things will be there, sir. Don't worry, sir.
Mm.
Yes, sir.
So what we will do today is we'll look at first 20 minutes or so. We will look at the basics of epilepsy, and then
Sir,
we
one
will
second.
go.
You
Yeah,
can put in the my view. You can put standard. It will come full screen. Put standard, sir.
my view is where.
View. Go to the option view. In the view option, put standard, sir. One is side by side speaker, side by side gallery, and standard. Click standard, sir.
That is not seen now. I think this is okay. No, you are able to see. No.
Yeah, we are able to see, sir. Don't worry, sir.
Yeah. So epilepsy is also called known as seizure, convulsion, fit, spell, and more. But we are supposed to use the technical terms for this condition. Now, yeah. So, what do you see here now? Is it focal or generalized?
Students can chat, put the
Yeah,
answers in the chat box.
yeah. So, what do you see here is actually uh, focal, because the consciousness is impaired. He is awake but not aware. You able to make out that?
Yes, sir. Yes.
Yeah. So what is a seizure? Seizure is provoked due to like brain tumor, encephalitis, stroke, and all that. These are new attacks or rare attacks. So when you use the term seizure, it should be provoked by something. While epilepsy, in definition, they call it unprovoked, and these are chronic recurrent seizures. So the key word here to remember is provoked and unprovoked. So new clinical definition of epilepsy. So is a disease of the brain with any one below present. So at least two unprovoked seizure 24 hours apart. One epileptic seizure and probability of further seizures. At least two seizures in the setting of reflex epilepsy. So what do you see in this? He has got pseudo seizures. He's a prisoner actually. So pseudo seizures is also called as PNES. Very important for psychiatrists. Psychogenic non-epileptiform seizures. So therefore, the seizure sometimes we call it as epileptic seizure versus non-epileptic seizure. So non-epileptic seizure will have pseudo seizure, conversion, dissociative attacks, syncope, breath holding spell, and so on. Now we have a classification. So there is a seizure classification different from epilepsy classification, and there is epilepsy syndrome classification. So the theme of the classification, the theme is the onset, is based on the onset. So whether it is focal onset or generalized or unknown. And then the other theme is whether it is motor or non-motor in nature. Symptoms are motor or non-motor. So awareness is the key actually. Awareness or consciousness is the key. So here focal onset seizures you can have focal plus intact awareness or consciousness. Or you can have focal plus impaired awareness or consciousness. Or you can have focal onset with bilateral tonic-clonic with loss of consciousness. And in generalized seizures, you have generalized tonic-clonic. Here there is total loss of consciousness as the first event. And absence, a few seconds only the consciousness is lost. Or you can have myoclonic jerks and atonic seizures, loss of body tone, falls and all. So the key word to remember here is the awareness or consciousness. So watch the words, loss of consciousness, impaired consciousness, impaired awareness, unresponsiveness, discognitive. All these words should not be used loosely. You have to be accurate in using these words. So let's look at what is consciousness definition. Consciousness is an active process defined as awareness of the self plus environment. So if you look at localization of awareness, anatomical localization of awareness, so say you are sleeping and then you are awake. So the arousal is from the brainstem reticular system. It starts here. Can you see this? And then cognition kicks in, memory and language, and then you become aware, and then the behavior. So, for example, you are sleeping in the hospital. First thing that happens is you get awakened, or that process is called arousal. So it's from the brainstem where reticular activating system is there. Then your memory and language kicks in. Means you are sleeping in the hospital, you're on duty and things like that. Then you become aware of your surroundings. So that is the function of the hemispheres. And then you get up and go to the toilet. That will be the behavior. So two things that you have to keep in mind here is the arousal is from the brainstem and the awareness is from both the hemispheres. So, as neurologists, we are interested in again localization, anatomical localization. So, consciousness has got two components, wakefulness and awareness. So, wakefulness controlled by reticular activating system or brainstem. For example, this lady has got a brainstem hematoma. So, there is no wakefulness. She is total in a coma and she is ventilated. While in this situation, the awareness is from both the hemispheres, and for example, he is awake but not aware. What happened to the slide?
Oh, sir, I did something.
Huh?
Oh shit. Wait.
No.
Ganeshan, sir.
Can you see it?
Sir, you share, sir. You share. One more, sir. You share. Give sharing, sir. Share.
No. Are you able to see the slide now? No.
No, sir. No.
Oh, suddenly it disappeared. So share screen.
Yeah, sir.
Yeah,
Coming.
it's
Yeah.
come, no?
Okay, sir. Okay.
Yeah.
Enlarge, sir. Enlarge.
Uh, this top thing, no? How do I move it out?
Sir, go to views. View options. Go to view options.
View, I am not able to see.
Sir, next to you there is a green. You are viewing Joshi's. You are sharing. There will be options, sir. View options. Sir, first you enlarge your slide, sir. So there is something called as view. View. Yeah. On the screen you can see there's a some label view, sir. VIEW view.
View, I am not able to see.
It should be there, sir.
Under more,
Yeah, sir.
huh?
Yeah, more. Hello, yours is iPad, sir. MacBook.
No. Laptop only.
In
Anyway,
the right corner where the time is running, there is next to that there is a view, sir. View.
now I have full screen actually. Anyway, let's continue,
Yeah,
no
sir.
problem. Slides are not moving. You able to see the slide now?
Yeah, sir.
Okay. I think the slides are not moving. So,
Sir, you just close and share once again your screen, sir. Now again, share your screen, sir.
yeah, this was the one we are on, no?
Now you move, sir. Now you move the slides, sir. Yeah, it's
It's
moving, sir. Yeah.
moving. Yeah. So, did you get this point?
You can go back, sir.
The
Again.
neuroanatomical localization, you can make out when you go to see a coma patient, actually, you need to make this distinction between wakefulness and awareness. So, if wakefulness is affected, if the patient is totally comatose, that means the reticular activating system not working, brainstem lesion. If the patient is aware but not, the patient is awake but not aware, that means both cerebral hemispheres. That's how we make out. So next slide. So here what you see, the focal onset starts on one hemisphere, one part of the brain, and then it spreads to the other side. That is why in focal onset you will find aura, and there will be focal motor or sensory phenomena. And the EEG will have a focal abnormality, and MRI also will be abnormal. But if this focal onset reaches the brainstem, so reticular activating system gets activated, then it becomes generalized. That is called secondary generalized. Now here what I'm showing is generalized onset starts, the first event will be the loss of consciousness because it starts in the brainstem reticular activating system. So first event the patient is knocked off, and there is no warning, no aura. So that is the distinction between focal onset and generalized epilepsy. This clear?
Yes, sir.
Yeah. So EEG will, in this case, might show a generalized discharge. The slides again not moving.
Yes, sir. Moving.
So focal onset seizure. So focal onset seizure, see here what you see is a focal aware seizure. In this patient is aware because only a small part of the brain is involved. But if it spreads out to both the hemispheres, then awareness will go. So that becomes focal with impaired awareness. And if it goes down to the reticular activating system, it becomes bilateral tonic-clonic, almost like generalized. So, olden classification we used to call as secondary generalized. Now it is called as bilateral tonic-clonic seizure. So these classifications keep changing, but the principle, the understanding, it's all the same. Rules for So now, what is the importance of classifying the seizures? Why do you need to classify the seizures? There are two reasons. One is uh, at least we can know that we are dealing with structural lesion. If it is focal onset seizure, we are dealing with a structural lesion. And if it is generalized, we know we are probably dealing with genetic epilepsy. The second reason is choice of medication. Choice of the drug is different in focal and generalized. So that is why you need to make a correct diagnosis of the seizure type. So I'll skip all these. So this is that new classification where they have changed terminology, and so focal onset, generalized onset, unknown onset. So under focal onset, awareness with impaired awareness. So it could be motor onset or non-motor onset. Supposing the epilepsy starts in the emotional area, you can have emotions like that. And focal to bilateral tonic-clonic. And in generalized onset, you have motor and again non-motor. Absence is considered as non-motor, the absent. And in the motor, you have tonic-clonic. So it's mostly quite self-descriptive, and easier to remember, is it not, compared to we used to call complex partial epilepsy and all that. Is the terminology has been changed now. So the terms no longer in use. Complex partial, simple partial, partial, psychic, discognitive. So the word partial only is gone now. It's all focal onset, focal onset. So focal onset partial seizure, simple focal, intact consciousness, complex partial or discognitive impaired consciousness. Secondary generalized is loss of consciousness. Is now called as bilateral convulsive. Now I'll show you some examples. Yeah, so you can see that left leg is having jerks. And if you look at the foot, can you see the left foot is smaller than the right?
Yes, sir. Yes, sir.
Yeah, that means the brain behind the left foot will be also smaller, right? So you can look at the CT or MRI and look at maybe right hemisphere will be smaller than the left hemisphere. This is very important. This is the only physical examination that we kind of focus on in epilepsy cases. You compare the hands, you compare the foot, look for asymmetry of the face, so that we know there is some hemiatrophy of the brain also. So this is a focal onset impaired awareness. This is a typical case of temporal lobe epilepsy. So the attack is over now. So so during sorry. So during this attack, what you observe is he has got automatisms. That is the newspaper hand. So you can
Yes.
hear the newspaper sound. He's doing fumbling with the newspaper,
Yes.
and the right hand goes into a dystonic posturing. So that will give us the localization. So that means it's arising from the left temporal lobe. So he has got probably a mesial temporal sclerosis in the left temporal lobe from this attack. Right hand dystonic posturing with left hand automatism. This is the video you saw already. Here, here you can see a medial temporal lobe lesion, limbic encephalitis, white area in the MRI is seen. So he's awake throughout the attack. He's awake, but probably is not aware. So this is called earlier we used to call this complex partial seizures. Now focal impaired awareness seizure. It essentially means the same. Now coming to generalized seizure. So generalized tonic-clonic, or olden days used to call it grand mal attack. So there is loss of consciousness, and in absence also there is loss of consciousness, but very few seconds only. You can hardly make out. In myoclonic there are only brief jerks, and in atonic there's brief loss of body tone and drop attacks. So these are the varieties of generalized seizures. This you can see a generalized tonic-clonic seizure. The tonic phase and clonic phase. You can so you can see all these features. The seizure begins by a sudden scream that is called epileptic cry. It is not to be confused with aura actually. It is not an aura. The first event is still the loss of consciousness. And bilateral axial flexion with internal rotation of both the upper limbs. And a slight non-forced rotation of the head to the right is then followed by a clonic phase. The second tonic phase occurs 55 seconds after the seizure onset, followed by bilateral clonic jerks and stertorous breath, post-ictal headache, and limb stiffness. You can also see the EEG changes during the attack. see the EG activity. Focus on the EG. Whenever the EG starts, she becomes unresponsive. Any, yeah. So you can see that she becomes absent or absence. It's only lasting for a few seconds. And these are very difficult to make out sometimes in children. It's totally missed for a number of years, and children just get stuck off and on, and parents are not able to make out that they have epilepsy. So look at this boy, what exercise I do is lift your hands when the absence attack starts. So you can see the EG. So this is like normal EG, this part, and see when the attack starts, it's epileptiform discharges occurring at 3 hertz, specifically 3 hertz spike and wave discharges. So I will tell you when the attack starts now. Can you see the attack now? There is some little nystagmus going on also in
Yeah,
the
yeah,
eyes.
yes, sir, yes, sir, yes, sir.
Yeah.
Yeah.
So
Sir, where is the three wave spike in EEG, sir?
now the attack is over. So that's all. This is called absence epilepsy. What are you asking?
The three wave spike and wave pattern.
This is what see. Can you see my mouse arrow?
Yes, sir. Yeah.
So this is normal
Yes, sir.
EEG, and from here it starts. So these are all three per. If you count these, it will be 3 cycles, 3 hertz. So these are the spike and wave.
Okay,
You can
sir.
see the spikes, all throughout the EG.
Yeah, yeah,
Yeah. So this whole phenomenon is called 3 hertz spike and wave discharges. So it starts here, and that will correlate with this attack also. So now this is normal part of the EEG. So this is epileptiform discharges. Okay.
yes, sir.
Yeah. So those are called myoclonic jerks, commonly seen in juvenile myoclonic epilepsy. This is to demonstrate the loss of tone, or what we call as atonic seizures. You can see there's a brief time when the tone is lost and is almost falling. So absence, myoclonic and atonic are generalized, but no obvious loss of consciousness like in GTCS, because they are very brief and quick. So she is beginning to get the attack. So it starts on one side. You can see,
Left
you
upper
can
lip.
see the automatisms uh, in the magazine, in the hand, the left hand, the magazine. So those are the automatisms. You can see the neck turning to one side, and she has impaired awareness. And then now you can see the tonic-clonic starting on the right side. So this is a complex partial becoming secondary generalized, or in the new terminology, focal impaired awareness to bilateral tonic-clonic. So from these videos, I think you have some idea about these epileptic attacks. Now, seizure is the first attack, and epilepsy means chronic recurrent seizures. Now, epileptic syndrome means like temporal lobe epilepsy, myoclonic epilepsy, juvenile myoclonic epilepsy, infantile spasms in children. So the analogy is like fever. Seizure doesn't mean much, it's fever. So what is the cause for fever? So that will be a pneumonia. And what will be the cause for pneumonia? It's COVID or SARS, whatever is the cause for pneumonia. So this is the analogy. This is how we give importance to seizure, epilepsy, and epileptic syndromes. So there are three parts to diagnosis. The first step is to find out what type of seizure, the attack history. Is it focal onset generalized? Is it myoclonic jerk? Then you add the history and EEG. Then you know the type of epilepsy. For example, you know it is a primary generalized epilepsy. Then epileptic syndrome. That will be the seizure type with history, clinical age, EEG, and MRI. For example, uh, juvenile myoclonic epilepsy coming at age, in the juvenile period, like 14, 15, 16 onset epilepsy. So that is how to write the diagnosis of epilepsy. Just like how you have in psychiatry this axis, in epilepsy also there are various axes: ictal phenomena, seizure type, epilepsy syndrome, etiology, impairment. So the five axes. In pediatric practice, I will not deal with this. It is totally different. What are the causes of epilepsy? For example, commonly seen causes, are focal epilepsy. So you can see this, in this case, it is neurocysticercosis. You can see these brain studded with these cysticercus, and you can even see the scolex here. Neurocysticercosis. This is herpes simplex encephalitis in a baby. You can see that baby is having rhythmic seizure on the right side. So that correlate with the left leads, left-sided, left hemisphere leads are showing epileptiform discharges here compared to the right. Then we will move on to some treatment aspects. Just hold on for a minute. Let me find the.
Sure, sir. Sure, sure.
You see the slides now?
Yes, sir.
Yeah. So why it is important to make the correct diagnosis? Because if you start carbamazepine in a juvenile myoclonic epilepsy, the myoclonus gets worse. So that is the importance of making accurate diagnosis. Again, the slides are not moving.
So you can close and share screen one more time, sir. Sometimes it will get
Uh,
hang.
you able to see the screen now?
Yes, sir.
Yeah. For some reason, the slides are not moving. Uh, Progressive myoclonic epilepsy. This you may not be able to make out this. What is this? This you may have seen. Tuberosclerosis. Can you see this? Adenoma sebaceum here and these calcifications, small tiny calcifications are there. And the skin lesions. So this is a case of tuberosclerosis. So tuberosclerosis, you may be seeing some of these patients as mental retardation and ADHD and the spectrum tuberosclerosis complex. Here you can see the face of the child having the coffee LA spots, and mother also is having adenoma sebaceum. So as the patient comes in, you can make a diagnosis of mostly they will have focal onset seizures. So what is the difference between aura and automatism? Aura is what the patient is aware, while the automatism, the patient is not aware. So this will be in focal onset seizures. If you don't have time in the clinic, how do I make out whether a given patient is focal onset or generalized? I ask only one question. Do you know if the attack is coming or not? So if they say yes, I can know that the attack is coming. That means definitely you're dealing with focal onset. If the answer is no, that will be generalized. Aura. That is about aura and automatism. So this is called mesial temporal sclerosis. You can see the hippocampus. Compare this side and this side. This is hyperintense and it's shrunken. It's smaller than this. This is the hippocampus on this side. The three A's in typical TLE: epigastric aura, behavioral arrest, and automatism. There are a lot of so when you get these slides, you can download them and you can see them. Now I'll just go to the management guidelines. So according to the guidelines, it's very easy to remember. Focal onset epilepsy, whether it is focal onset or whether it is focal onset with loss of awareness like TLE, frontal lobe epilepsy, the drug of choice is carbamazepine or oxcarbamazepine. While in generalized epilepsy, in generalized tonic-clonic, absence myoclonic, it is valproate in male patients and levetiracetam in female patients. Maybe in the new drug has come now, brevit, what is that? Brevitiracetam. So that will might take over this levetiracetam now. But if you follow the basics, you know, I was at Satyasai Hospital for about 10 years. In the first 8 years, I saw 100,000 patients personally, 100,000 consults was that. So that means to say we have a large number of patients attending the neuro screening clinic, around 150 per day. Most of these patients are outstation from North India and West Bengal, and they come with uncontrolled epilepsy. So there are two residents sitting in the screening block. Their job is to cut down all the medicines, especially the newer medicines, and they give them Zeptol because most of the poor patients they will have focal epilepsy. They will have TB, some lesion or scars, or neurocysticercosis, or some developmental issue. So most of them will have focal epilepsy. So the Zeptol is like 1 rupee tablet, Zeptol, carbamazepine. So we just stop all the other medications and put them on Zeptol, and 90-95% of these patients get controlled. And they come all the way from West Bengal just to get a prescription of Zeptol, you know, because they found relief there, they keep coming back again and so the funda is stick to the rules, stick to the guidelines. You will have always better results. So choosing monotherapy, always choose monotherapy. Don't go for more than one drug, you know. So if it is an adult male, generalized valproate. If it is focal, you go for carbamazepine. If it is a female, because valproate has got side effects. Yeah, what are the side effects in ladies? It's polycystic ovaries. They can have hormonal problems, and if they become pregnant, valproate is the worst drug that can cause fetal abnormalities. So valproate is avoided in pregnancy. You can choose levetiracetam. In children with generalized, you can use valproate, and elderly, you can use levetiracetam. So the lamotrigine is a good alternative in all the groups. Now, how do you typical prescriptions? How do you start Zeptols here? Always start in a small dose. So half zero, half 1 week, then 101 1 month, then 102 if the seizures are not controlled for 2 years. Similarly, all anti-epileptic drugs start in a small dose and build it up slowly. Now, AED selection for the initial monotherapy. So if it is a child, school child, you're worried about learning, cognitive and all, then you can choose lamotrigine over phenytoin, phenobarbital and tegretol you can avoid. Supposing somebody has liver disease, then you can choose topiramate or pregabalin over tegretol, phenytoin and valproate. And if there is allergy problems, this tegretol and phenytoin is known for allergy, lamotrigine including. So you can choose topiramate or valproate. And if it's an obese patient, topiramate is very good because valproate gabapentin causes more weight gain. And a wrong choice of AED in epilepsy patient can lead to status epilepticus. For example, if you have a patient with absence myoclonic GME, you give carbamazepine, phenytoin, they can become status epilepticus. And avoid benzodiazepines in this Lennox-Gastaut and infantile spasm. And gabapentin pregabalin can create myoclonic epilepsy. Can One of the toxic effect of pregabalin is myoclonic jerk. Similarly, in absence and myoclonic, avoid this vigabatrin, tigabine, and all that. And various syndromes, for example, absence, avoid phenobarbital, can make it worse. This I told you, tegretol, carbamazepine versus juvenile myoclonic epilepsy. Now, what is the rational polytherapy? So here we have the syndrome, idiopathic general epilepsy, here partial epilepsy and epileptic encephalopathy. So monotherapy, rational polytherapy and irrational polytherapy. You can see. So in generalized is a good combination of valproate and lamotrigine, or lamotrigine and topiramate, because topiramate is also a broad spectrum like valproate. So this you can use. And in partial epilepsy, the only thing you have to remember is start with carbamazepine, not control. You add cloba. So you add cloba, and that is the best combination. Epileptic encephalopathy is very difficult to try to find out the cause, and if there are any causes, you have to treat the cause. And in pregnancy, avoid valproate and multiple AEDs. So before pregnancy, you can change to levetiracetam, and during pregnancy, don't change. And carbamazepine is better than oxcarb in pregnancy because of the blood level maintenance. And always give folic acid along with the aid. Now, in juvenile myoclonic epilepsy, uh, monotherapy, if there is predominant myoclonus, your choice is levetiracetam. If it is predominant absence, means absence, then you will choose lamotrigine. If there is obesity, you can try topiramate. And if there is migraine, you can try topiramate because topiramate is useful for migraine also. So now I'll take, uh, you want to have some question answer now?
Sir, sure, sir. Probably one of the question which I got, sir.
Uh,
Uh,
1 minute.
Sir, does the automatisms occur on the same side of the lesion?
Automatisms have no localizing value.
Okay.
Only the dystonic posturing I told you, no? Only
Yes.
the dystonic posturing has got localizing value.
Now I request participants to unmute. Kindly unmute, and if there are questions, you can ask. Since there are around 27 participants, we can take the questions directly. PG students, feel free to ask any questions, doubts regarding the type of the seizures or classification, the semiology, and the treatment aspects. Sir is very happy to answer, and he likes interaction. That is what we heard from the your first presentation.
Or if you want to ask management questions, anything.
Yeah, here easy people can talk.
So I have, if you want, there is one more case, very interesting case that I can show you. Maybe it will take like another half an hour. And this is very relevant to the psychiatrists. So
Sure, sir.
can we have it next time or you want to finish it now?
Hello.
Yeah,
Hello.
go ahead,
Yeah.
go ahead,
Yeah.
doctor.
Go ahead.
Sir, this is Dr. Varsha. I would like to ask a question, sir. I wanted to know how to differentiate the stereotyping in autism and some automatisms.
Varsha, can you come back again? Your voice is not clear.
Is it audible now, sir?
Yeah, yeah.
Yeah.
How do we differentiate the stereotypy of autism and automatism in
Yeah.
clinical practice?
Yeah. In clinical practice, it is very difficult actually. What we do is we do an EEG.
Okay.
If you're lucky, you can pick up, and then you can also look at the time of attack, the responsiveness and things like that, but autistic children, they may not respond or anything. So
Oh,
it's a difficult thing to make out actually. So these are the so many epilepsy can be misdiagnosed. This is one of the situation where epilepsy can be misdiagnosed. Night terrors. There are so many other conditions. So this is one of them.
Sir, we have one question by
Yeah.
Dr. Rekha. Sir, how to shift from carbamazepine to oxcarbazepine in patient who has developed diplopia and ataxia with carbamazepine?
Well, both drugs can cause that. So what you can do is to reduce the carbamazepine and C, reduce the dose of carbamazepine and C, and 200 milligram twice daily dose will be equivalent to around 300 of oxcarb twice daily. So you can easily switch also. And when you switch to aux carb, what will you look for? You look for sodium. It can cause hyponatremia, much more than carbamazepine. Maybe.
Okay, sir. Thank you. So the
Okay.
next question, levetiracetam and behavior worsening in children's.
Yeah, yeah,
We have
that
seen
is
in adults
that
it
is.
can cause
Uh,
behavior disturbance.
Unfortunately, this levetiracetam has become like a very fashionable drug, and mostly neurosurgeons and even neurologists they start using levetiracetam left and right. They don't stick to the rules, and not only children, elderly also they will have anger issues, behavioral changes, levetiracetam. So I am very aware of this, and when a patient comes to me, I always try to change. I try to find the diagnosis. If it is focal onset, levetiracetam is not the drug of choice.
Okay. Thank
So
you, sir.
I will choose carbamazepine, or nowadays it's going out of fashion, so you can use oxcarb. Or if you don't want to use oxcarb or carbamazepine, you can go for
Ah,
l- l- this one, Levisam,
Okay.
which is that.
You can, sir.
You can choose one of the drugs that are used for focal onset.
Sir, we have next one of the question.
Yeah.
In pregnancy, which is the safe anti-epileptic drug from Dr. Sanjay?
Carbamazepine is safe. Lamotrigine is safe, and most of the new drugs not yet known.
Sir, what
Only
about
thing,
levetiracetam?
levetiracetam is safe. That is why I told you shift from valproate to levetiracetam in pregnancy.
Okay, sir. Thank you, sir. Yeah. Any other uh, response from the audience which they want to have a discussion with, sir? We have another 5 more minutes
So
before we
yeah,
conclude.
what we can do, next session also we can continue epilepsy,
Yes, sir.
and yeah, I will show you some very relevant cases to psychiatry.
Sure, sir.
We can
Sir,
continue this epilepsy only next.
yeah, sir, we have next class is on clinical approach to movement disorders. So you can start with epilepsy and then you can move on to the movement disorders.
Okay,
We
so
have
that
movement disorders at next class.
okay, okay. Oh, you have fixed all the classes, huh?
Yes, sir. The next one is on 31st March, next Wednesday. It is to the
Uh,
movement disorders.
okay.
Initially, we can have your remaining part of the epilepsy and then
Yeah,
we can move on to the
then
movement disorders.
maybe in 10 minutes I'll show you this because this epilepsy, it's a large topic, is it not?
Okay.
It to get a hang of it, you need some time. Just
Sir, we
such a
have
short.
a, if you don't, we have a class on basics of EEG. During that time, can we club this?
That also maybe we can do that
Yeah, because
little.
I'm getting response from the students saying that they want a full class for the movement disorder without
Okay,
clubbing with any other topic.
okay.
Yeah.
You want to see this case now? Then
Yeah, sir, we can go ahead, sir. No problem.
yeah, so that we can do then.
Yeah, sure, sir,
Another
sure.
10-15 minutes maybe.
Yeah, sir, definitely, sir. We can have it.
Yeah. Yeah. Can you see the screen now?
yes, yes, yes.
So it's a case of the patient name was Vismaya, which means puzzling. So Vismaya was a 9-year-old girl from Calicut. She was normal till the age of 8 years. Then her dearest grandma died, and 5 months later, she started getting attacks in sleep. So daily about 5 attacks in sleep and 2 attacks daytime, in spite of 4 medications. So daily attacks since 1 year, mostly in sleep, suddenly wakes up, starts with tingling sensation of the left leg, then stare, eye open with shaking movements of the limb, kicking, laughing, crying, pelvic thrusting, vocalization. And she is awake and aware during the attack, answers questions, and each attack lasts about 1 minute. So you can see she went to an epilepsy center in Calicut, and you can see the diagnosis they are thinking of. They are not sure what it is. Sleep terror, seizure, parasomnia, left focal sensory seizure. So see the difficulties in the diagnosis. This is a discharge summary from Manipal Major Medical College. This patient was kept in neurology for 10 days and then referred to psychiatry. So psychiatrist they discharge her with a diagnosis of dissociative disorder, episodes of movements of the limbs forward. So I'll show you the video also. You can see this discharge summary from the psychiatrist, a major medical college, and you can see the axis here: dissociative disorder, restless leg syndrome, nocturnal myoclonus. See the difficulty in diagnosis. So they discharge around amitriptyline and clonazepam. And when the patient came to us, she was on these 4 drugs. Pramipex, no, Pramipex, all thinking it is restless leg syndrome, and Rivotril. When you are not sure of something, you give Rivotril. Certa is antidepressant, and Diva is valproate. So she was on these 4 drugs. Now you can see long-term video EEG monitoring that we did. You can see the attack.
Ora.
He's telling her name, Miss Maya. Attack is over. So now you got an idea of the attack, no? So there are 3 more videos, almost similar. This is the video telemetry report. You can see that she had 38 attacks in 65 hours of video. So from the EEG, we could make out that probably these are suggestive of frontal lobe epilepsy, gelastic type, arising possibly from the right frontocentral region. That is why she gets that sensory phenomenon in the left leg she was describing. And frontal lobe epilepsy you have lot of action with the hands and legs, like motor movements are very prominent in frontal lobe epilepsy. So hyperkinetic automatisms, what they are called, that is suggestive of frontal lobe epilepsy. Because frontal lobes is where all the motor areas are there, no? So naturally you will get lot of motor movements. So 38 attacks, we stopped all 4 drugs, and we started around carbamazepine. Why carbamazepine? Because that is what is written, drug of choice for frontal lobe epilepsy, focal onset epilepsy, carbamazepine. So we were also a little scared, so we put her on, because stopping all the 4 drugs, we put her on levetiracetam. So attacks fully controlled in 3 days, and follow up 3 months later, no seizures. So they were. She's trying to tell that now all the attacks are stopped. I have no problem.
Yes. Participants, any doubt?
Yeah. Now, so this is called. Yeah, it's actually a genetically determined type of frontal lobe epilepsy. Can you hear me now?
Yes, sir. Yes.
Yeah, yeah. So this is a good example, no? It's a very eye-opening thing for psychiatrists also,
Sir, some of the students are asking, can we get a EEG of the Vismaya? We'll send you once the series is over, the PPTs.
Yeah, yeah. We'll share whatever we are presenting, and more we'll share, and they can download it, all the slides as it is, including the videos, EEG, everything will be there in that.
Sir, I had a doubt.
Yeah.
Yeah, go ahead, go ahead.
Sir, the thing is, this Vismaya case, we see, many patients with similar presentation. I mean, from what a psychiatric resident, what I can see is there is abnormal movement of, external limbs which are non-repetitive, which are non-rhythmic, and neurologist has seen, says that MRI is normal and EEG is normal. So definitely we'll make a diagnosis of pseudo seizure. So I mean, how we can actually differentiate actually, because before referring to a psychiatrist, this case was again seen by a neurologist where MRI and EEG was said to be normal. I think they've taken one set EEG, they have not done a video EEG. But how we can learn, or how we can keep a more suspect in this, actually in this case, because she, from whatever I have seen the video, she actually looks like a case of pseudo seizure.
Correct. That's why you're talking about a medical college where she was kept as inpatient for 10 days, then referred to psychiatrist.
Yes, sir.
Yeah. So that is the importance of staying with the basics, that uh, this long-term EEG monitoring is very, very important in such cases, difficult cases. So we were able to capture the attack along with the EEG, and then we correlate the EEG finding. Sometimes you can't catch it in the EEG, but at least you can see the attacks. And she's clearly saying that it starts in the left leg, and you have to give some credence for that. And the frontal lobe epilepsy looks like pseudo seizures because they will be moving the hands, legs, and all. No, these are the automatisms. So if you are aware of frontal lobe epilepsy, you will be able to make a diagnosis and give the correct treatment and see the response.
Okay, sir. Thank you, sir.
Yeah, we followed her up for 2 years, and we removed the levetiracetam. She was good with only carbamazepine actually. This is a very good example, no, of correct diagnosis and correct treatment.
Thank you, sir. Thank you.
Yeah.
Yeah, thank you, Dayanand. Others, any doubt? Yeah, please, Sampath sir, go ahead, sir.
Mm, so I think we'll meet the next time, no?
Sure, sir.
Yeah, we'll movement disorders. You want?
Yeah. Participants, thanks for your very patience listening, and it was a very quality discussion after the very good quality presentation from our Joshi sir. I thank Dr. Joshi sir for his very precious and valuable time which he is sparing on every week Wednesday. I request all the participants for the next class. It's on movement disorders. Please read about the basics of that, and we can have a better, even more better discussion. And it will be 7:30. Kindly log in so that you will not miss the initial part of the basic presentation. Thank you all the participants. And thank you, Joshi sir, on behalf of Indian Psychiatric Society Karnataka chapter, sir. Sir, you want to tell something?
Yeah, the problem with the like movement disorder is such a huge topic, and in 1 hour time, So if you
Sir,
say
we
like
would like you to have mainly on Parkinson's, chorea.
yeah,
I think these two, the Parkinson's and chorea, plus some bit of Parkinson's related. Many of
yeah,
the
yeah,
psychiatry related, like tardive
psych,
dyskinesia,
yeah.
dystonia, we can also touch
Mm,
upon that. But mainly we want Parkinson's related
mm.
chorea, then dystonic movements. These
Because
things.
just covering the theories of no much use. You can read it anywhere, right?
Yes, sir.
But you need to get that feel of it. How we think and how we deal with this. And some of these cases you need to have an idea of about some cases that you don't see in psychiatry also, but related to neurology.
Yes, sir.
So yeah, so movement disorders means a lot of videos and a lot of it
Sir,
will be like it will
Can
be
we have it in 2 classes, sir?
yeah, maybe it requires 2 classes because Parkinson alone will be one class like that. Anyway, we will see how it goes tomorrow. I mean next week. I
yes, sir.
have I have in movement disorders very uh, highly treatable disorders are like dystonias and various type of dystonias. So that is treated with botulinum toxin injections. So that will be interesting for you, to see the patient, then see them after the injection, how it benefits and all that.
Sure, sir. We would like you to hear mainly on dystonias, then choreatic movements and Parkinson's related movement disorders, sir.
Yeah. And you can come with questions also, we can have question answers.
Sure, sir. Definitely, sir.
Hmm.
Over to our secretary, Dr. Somshakar Bijal, sir,
Yeah.
for vote of thanks for today's presentation.
Yeah.
On behalf of Indian Psychiatric Society, I thank Dr. Joshi sir for his valuable inputs with respect to the diagnosis of epilepsy and its newer classification and its management. It was quite useful, sir. Thank you very much. So on behalf of IPSKC, I thank you, sir, once again. And I thank also Mr. Ganeshan from Microlabs. And I thank the moderator, Mr. Dr. Sachin. And I thank the Telearago team coordinator, Dr. Mahesh Gowda, and all the participants. I request the participants to spread the news about this Neuro series because this it's very difficult to get such an expert teacher, especially Joshi sir, because I attended many of the conferences where Dr. Joshi sir has taught us many things. Really, the youngsters should not miss that. So inform most of the pages so that they can get the many benefits out of this series. So I once again, on behalf of Indian Psychiatric Society, I thank one and all, sir. Good night, sir. With the
Thank you,
permission,
thank you.
can I ask Ganeshan sir to close the session, sir?
Yeah.
Yes. Thank you, sir. Good night, everyone.
Okay.
Thanks a lot. I think it. I mean, though I was not there, I was able to hear the very interesting, talk of Dr. Joshi on epilepsy, and because we have a lot of anti-epileptic drugs, so for me also it was very interesting, and I wholeheartedly thank Dr. Joshi, Dr. Sachin, Dr. Bijal, and everyone, and particularly the participants, of course, without whom this program is of no use. So therefore, I thank each and every one of you to have been a part of this wonderful program and session. And we are sure everybody would have learned out of this and the practice of psychiatry. Thank you. Thanks a lot and good night.
Thank you, sir. Thank you. Good night. Good night, everyone.
Thank you.
Good
Thank
night.
you.
Good night. Good
Night.
night.
Good night.
Good night.
No, I have to end the meeting.